Not sure why that's still there. Huh. Okay, let's, there we go. All right, hopefully we're working now. Just real quick, this is just to orient you to the diagram I passed out to you. It shows the spinal cord, okay, on the one side, and then it has all the different major, a lot of the major pathways in the spinal cord labeled here on this side. Gives you a lot of those, both motor and sensory, most common major pathways on this side of the spinal cord here. And then on the other side, you see, the dorsal root exiting here, the ventral root exiting here. Here's the spinal nerve right here where it exits just outside of the vertebral foramen, okay, as it's exiting there before it divides into this dorsal ramus that goes toward the back of the body, and then the big ventral ramus, which goes to supply most of the front of the body, okay? And then you notice within that nerve there is sensory information coming in, in these nerves, and that's including in both the dorsal ramus and ventral ramuses. There's sensory information coming in, and then there's motor information going out, which we're going to talk about today. And there's also in the thoracic spine, in the lumbar, in the upper lumbar, there's the autonomic or sympathetic fibers exiting as well. Okay, so that's here in that little lateral horn. It's also known as the intermediolateral cell column as well. So, but it's easier to say lateral horn than that. So that's going to exit out. It comes in through this white ramus first, makes a synapse, may go up or down a few segments, but it makes a synapse in the sympathetic trunk ganglion and then exits out through this gray ramus, okay, before it then goes back either into the ventral ramus or dorsal ramus to go supply the front or back of the body. So just a little easier to see all that in one shot. Okay. Oops. All right. All right, motor system. Is anybody a big tractor pull fan in this class? You're going to admit to that, I have been to one tractor pull. It's good. It's fun to go one time, just the pure horsepower shaking every bone in your body, and then the nitrous hitting your eyes and making your eyes water. So. All right, so we're not talking about that motor system. We're going to talk about a little more complex motor systems. So let's take a look at your other page or handout there that just kind of highlights all the major fundamental components of the motor system. Doesn't show all their interactions, just showing you kind of components and subcomponents of these particular areas of the motor system. So starting in the top, we have the cerebral cortex. That's where voluntary motor system happens. That's when we're doing goal-directed, task-directed activities. And there's specific areas of the motor cortex, of the cerebral cortex, and those are the motor areas of the cortex, which include three primary areas: the primary motor cortex, the pre, and the supplementary motor cortex. Those are the main areas that drive or supply information that's going to drive task-oriented, goal-directed movement. We have some control circuits. We have these circuits that don't have the control circuits. The basal ganglia and cerebellum have no direct connection with anterior horn cells. They do not directly communicate with anterior horn cells. They communicate back to the cerebrum or from the cerebellum into the brainstem areas to then influence descending tracts that will eventually communicate with anterior horn cells. So they modulate motor output. They don't directly send signals to anterior horn cells, but they're very critical to modulating overall motor output, making it look coordinated, and also modulating just the overall amount of movement you do and how quickly you do movement and so forth. So we'll get into that when we get in. We'll do a whole session or day on just the basal ganglia and cerebellum and their role in motor control. We're not going to talk about those today, but I want you to understand that none of what we're talking about today will function properly without those control circuits influencing these pathways we're going to talk about today. Then we have these descending pathways that carry information through, typically from the brainstem or from the cerebral cortex down through the brainstem and spinal cord. Okay, so we've already talked about all these sensory pathways ascending. Now we're talking about descending pathways today, motor pathways. Those can be grossly divided into two major activating systems, a medial activation system and a lateral activation system. And then we're going to further subdivide those into the individual pathways or tracks that make up those systems, those larger systems. So you'll see here on the medial activation system, we have 5 separate tracks. Tectospinal, the anterior or medial corticospinal tract, the medial vestibulospinal, the lateral vestibulospinal, and then the pontine reticulospinal tract. Understand that your current textbook does not mention the tectospinal tract. The current edition, the previous edition does mention the tectospinal tract. I do want you to be aware that most textbooks and most significant resources do talk about a tectospinal tract, so I want you to at least be aware that there is a tectospinal tract. So we'll cover that today. And then the lateral activation is made of the lateral corticospinal tract, the rubrospinal tract, and the medullary reticulospinal tract. Okay, and in your latest edition of the textbook, hardly even briefly mentions the rubrospinal tract, and I'm not sure why, but there is some more newer evidence the rubrospinal tract may not influence as much as we thought it did, at least in humans. It's much more robust in primates, but they hardly, it's like a couple sentences on the rubrospinal tract. But I've always, typically talked about a little bit more. We'll give you a little bit more of the traditional concepts on what the rubrospinal tract does. And actually, in your current edition on there's a table that shows what the rubrospinal tract does, and it talks about extension of the fingers, and that I think that's a misprint or a mistake. It's always, I've heard of the rubrospinal tract being influencing more flexion of the upper extremity and of the hand than it does extension. It's actually more of a facilitator of flexion than it is extension. So I think that's a mistake in your latest edition, the bigger edition of that textbook. There's a little table that says rubrospinal tract, and one of the functions says extends fingers, and it flexes fingers is what it does. And then eventually those pathways talk to some lower motor neurons, the ones that are at the cell bodies or in the anterior horn of the spinal cord. Alpha motor neurons, those are the ones that go to the extrafusal muscles, the muscles that are making the motion or moving your limbs. Those are the alpha motor neurons. The gamma motor neurons are the ones that go to the muscle spindles embedded within the muscles, the little ends of the muscle spindle. Okay? When you think about movement, you really need to think about, a couple things here. There's a lot of different systems in play here, and they're all just as important as the other. One's not necessarily more than important than the other. We typically think the cerebrum is this really important structure that guides goal-directed movement, but the spinal cord has very complex reflexes that mediate movement, that if your spinal cord didn't work, you're not going to be doing very well with just your cerebrum working. Brainstem too, there's a blending or a blurring of their importance depending on the task. If I'm sitting in one location doing a very fine motor skill task where I don't have to worry about keeping my balance or posture, sitting in a nice supportive chair, and I'm tying a fly or doing crocheting or something like that, that requires much more of that cortical influence from those primary motor strips to these little muscles in my fingers that are doing very discrete, individualized movements and so forth, especially if it's a new movement that I haven't learned before and I'm really trying to learn it at the same time. That requires a lot of that cognitive involvement. But if I'm just sitting or if I'm just standing up here and not doing a lot of movement, pretty much everything, I'm not using much cortical involvement at all. I'm just using my brainstem pathways to maintain my bias to extension to keep my body upright against gravity. But if I now superimpose a voluntary movement, now it's a little combination. I'm using my postural gross medial activation system to keep my balance, and I don't have to even really think about it while I'm doing a conscious thought of reaching for this object. And so there's a blending there. So depending on the task, depending on what you're doing, one area of the system be more important than another, and that can change. movement is always shaped by your environment, okay, or the context of what you're doing. So, you know, if I'm doing something where I'm lifting an object that is light versus heavy, or big versus small, or I'm standing on sand while I'm doing an activity versus on a firm floor, or I'm standing in a room that has lots of light or not a lot of light, all those things place different demands on my motor system and how I achieve that task. So when you're designing your physical therapy treatments for your patient, that's what we do. We teach motor skills, right? That's pretty much what we do, teaching exercise, teaching somebody to walk better. We are motor skill teachers. So you always want to be thinking about that. Is you have to, your biggest job is designing the environment so your patient can be successful in what you're trying to do, setting up the task for success. It's also the intentions of the performer. So if a person's not motivated to do something, they're not going to probably learn that skill or do very well at that skill. So you have to, again, as a physical therapist, always be thinking, is this a task that I'm setting up for my patient? If they're learning, is it inherently meaningful to them? Or are they just saying, you know, doing this, I don't see why doing 10 of these leg lifts is going to do me any good, you know? So if there's not intent to learn and there's not, you know, motivation by the client, the motor learning and the motor control that go along with that are not going to be as good. So why do we move? You know, we do typically move most of the time to accomplish some type of task or achieve a goal. So when we think about physical therapy, most of what I do when I'm designing a treatment is a task. It's designed around a task, you know, accomplishment of a task, not a discrete individual movement. You know, I don't just work on flexing your finger. We work on reaching for that task or grabbing some object or something like that. So movement, the ability to move from one location to another, locomotion, is one of the most important, you know, fundamental attributes of a living species because it liberates the organism from their constraints. It can move about its environment. It can get away from threat. It can interact with things, learn new things. So there's something very primitive about being able to move within your environment, and that's a goal for most of your patients. And that's why a lot of your patients with strokes and so forth, if they can't walk, their number one goal is to be able to walk and move, even before they have the ability sometimes to use their arm. Now, eventually that becomes, once they're able to walk and move with a certain level of independence and ability, then they start to say, well, I really wish this arm would start working now too. But until then, a lot of times I just want to get up and walk, and which is great for us as physical therapists because most of our patients are pretty motivated to walk and move. And then the good part about walking and standing are fairly gross postural movements that don't require a ton of cortical involvement. And so it's actually easier for us to get patients better because we can rely on the medial activating systems and some of the spinal cord circuitry to help our patients move, even if there's significant damage in the cerebral cortex, where OTs working with fine, discrete movements of the hand, when they've got lesions up in the cerebral cortex, it's much harder to relearn and gain back that than it is. So we've got a much easier job. We always look better in their eyes. Plus, they're typically motivated to do that. More than half the nervous system is directly involved in motor performance. More than half of your neurons are directly related to in some way of providing you with good motor performance. And therefore, disruption of motor control mechanisms is the most common manifestation of disease in the central nervous system. So the most common symptom or sign that you will find in a patient is some disruption in motor performance or motor ability is the most common indication that somebody's a neurologic problem. So, this is the sequence of events and systems that are involved in voluntary movement. So this is where you are the one choosing to make the action and making a conscious decision to move something or do something, okay? So you make that conscious decision, okay? The first impulse starts in the motor planning areas, okay? This is kind of premotor and supplementary motor areas, are areas that you start to plan movements. You're actually looking for previously stored programs that are similar to what this task you're about to do. If you've done it before, you find some similarly stored programs that you know you can send signals then. Then that signals the primary motor area to send a signal down, okay? But that stops and works through the control circuits first. Primarily we're meaning the basal ganglia here, okay? So actually it's not like you send a signal directly from your primary motor cortex right down to the anterior horn cell to create the action. If it's a conscious voluntary movement, it actually goes down into the basal ganglia and it does a little loop. And it loops back through the basal ganglia, back up to the cortex to finally release the signal that then sends that signal from the cerebral cortex down to the anterior horn cell. So conscious movement doesn't just go start directly down and go directly to that anterior horn cell. It actually goes through a little loop through the basal ganglia, back up to the cortex to finally then release the signal to go down to the anterior horn cell. So it has to go through this little basal cortical loop, basal ganglia cortical loop before it actually does that. So we'll get into that when we get into the basal ganglia, but just so once you've been processing the control circuits and then you've told the motor planning and the primary motor areas to go ahead and release that signal down through the descending motor pathways, typically, most of the time, those are going to also fall on spinal interneurons. Okay, so some of those descending motor pathways, that the cortical spinal tracts and the brainstem tracts will fall in the anterior horn, not directly onto an anterior horn cell. Some will, but a lot of them will fall on interneurons, spinal interneurons near the anterior horn cell, and can influence the anterior horn cells through that connection with the spinal interneurons. And some of those spinal interneurons are more inhibitory, some are more facilitatory, so that just helps modulate overall output of what's going on. Some will directly interact with those lower motor neurons, those anterior horn cells that are going to the skeletal muscles. Okay? So there's a little complexity that goes along with this. And I'll admit, your book sort of butchers the whole motor system a little bit. It just doesn't do it in a very logical, linear way. And we're not going to talk about, muscle contraction and sarcomeres and all that stuff. You guys had some of that in physiology already, so we're kind of skipping that part. So we're just going to talk about the neural parts of control here related to that. Okay. When I was going through the slides last night and this morning, I did notice that some slides were different in order than what your current textbook is, so I modified some order, but the content, so if you've got slides printed out, the slide content didn't change, but I might have changed the order a little bit, so I apologize if that messes you up. But I did reloaded the new PowerPoint with the current order this morning on that. So we're going to start with the lower motor neurons. So we're actually starting out in the periphery. I kind of wish they'd start, in the central nervous system, work our way out, but we're going to start in the periphery, just like your book does, and work kind of our way back. Okay, so two types of lower motor neurons. Okay, so a lower motor neuron is where it has a cell body in the anterior horn, and then its axon is in the periphery. Okay. It's considered at this point, it's considered kind of acts like a peripheral nerve but the cell body's technically in the central nervous system, in the anterior horn cell, in the spinal cord, but the final axon is out in the periphery. Okay, and you have an alpha and gamma motor nerve. Okay, so these are lower motor neurons. The pathways that we're going to talk about, any of the neurons in those pathways, those are called collectively as a whole group upper motor neurons. Okay. Any of the neurons that are in that medial activating pathways and lateral activating pathways, any of those axons that are associated with those, and those neurons are all collectively called upper motor neurons. So that's what we mean by upper versus lower motor neurons. So when we talk about damage or disease or injury, if you hear somebody has a lower motor neuron deficit or problem, that means either the axon out in the peripheral nervous system has been damaged or impaired, or the cell body, just the cell body inside the anterior horn itself. That's a lower motor neuron problem. If you kill off, damage, tweak, whatever, any of that cell body or its axon, that's a lower motor neuron problem. If you damage the descending pathway anywhere before it touches that anterior horn cell or that lower motor neuron area, that's an upper motor neuron problem. Any stroke, tumor, whatever, trauma to any of the neurons down through the cerebrum, brainstem, spinal cord, before it communicates with its anterior horn cell, that's an upper motor neuron problem. Okay? And they have very different characteristics of how they influence what the symptoms you'll see in a patient if it's an upper or lower motor neuron problem. You can also have patients that have both. upper motor neuron problems and lower. If I've got a patient with severe diabetic neuropathy that causes wasting and weakness in the distal limbs, but they also end up with a stroke. So now I've got an upper motor neuron problem combined with a lower motor neuron problem. So they're not exclusive. Patients can have both at the same time. So alpha motor neurons, the cell bodies in the ventral or anterior horn of the spinal cord, they exit the anterior root, okay, the front part. Remember, efferent tends to go out the front door there of the spinal cord, and it innervates skeletal muscle, the extrafusal fibers, not the muscle spindle, okay. The neurotransmitter it uses is acetylcholine, okay, and it falls on a fast nicotinic, acting receptor to cause that contraction. The type of axon, the classification of the axon it uses is called an A-alpha axon, okay? Just like we had classifications of axons in the sensory system when they're out in the periphery, those peripheral axons, we had those classifications, ones, twos, A deltas, all that stuff. We have a classification system for the axons in these peripheral lower motor nerve axons in the periphery. And this just happens to be called an A-alpha. It's a large myelinated fiber because it's sending fast signals to get to that muscle to make quick responses, to contract quickly so you don't fall over, so you can get out of the danger, those kind of things, okay? So this is just showing you, here's a bunch of anterior horn cells sitting there with their axons exiting out the little rootlets, eventually into the root, ventral root, and then into our mixed spinal nerve, which is containing sensory information and autonomic fibers if it's in the thoracic to lumbar area, and then eventually going to a specific muscle fiber. Okay. The other type of lower motor neuron is a gamma motor neuron. Okay, so gamma motor neuron also has its cell bodies in the ventral horn with the alpha motor neuron, so they're near each other because they essentially fire together. Okay. It exits the ventral root as well. It innervates the intrafusal muscle fibers. So there's little muscle fibers here just on the ends of the, I'll change it to like so here. You can see the yellow. On the ends of the muscle spindles here, there's some little intrafusal muscle fibers. And this is that little capsule that kind of encapsulates the muscle spindle and that fusiform nature, that tapered end on each end. Good question. Yes, assuming it is, but yeah. These are medium myelinated, so just a tad slower, but pretty close. And these are gamma, A gamma axons. That's the axon classification, is an A gamma classification versus a alpha. These are A gammas. Let's define this thing called a motor unit. So motor unit is a single alpha motor neuron and all of the muscle fibers it innervates. So most alpha motor neurons innervate more than one muscle fiber, okay? When you have muscles that are big, gross moving muscles like your quads, your butt, your glutes, those kind of things, you might have one huge anterior horn cell that innervates a lot of muscle fibers. It's a big muscle, but it's gross movement. It's just extending the knee, flexing the knee, extending the hip. It's not doing really fine control. So you can activate a lot of muscle fibers with just one cell and kind of have this gross kind of contraction that occurs. You don't have to do a lot of fine control with it. But when you get into muscles like your forearm, intrinsics of your hand, you have these smaller motor units. So you might have an alpha motor neuron that only innervates a couple muscle fibers, 1 or 2 versus 100. Because now you have the ability to fractionate movement much more and finely control pressure, movement, because you can, modulate, because you've got much, more sophisticated control of a lot more alpha motor neurons supplying a smaller number of motor units, so you get a lot more, ability to kind of regulate and finely tune your motor system, okay? And then a motor neuron pool right here is all of the alpha motor neurons that are associated with completely innervating an entire muscle, okay? And those alpha motor neurons may be at more than one spinal cord level. So in the bicep, you have both some C5 and C6. So in both the C5 and C6 areas, all the alpha motor neurons that end up with their axons going to the bicep, that's your motor neuron pool for the bicep, okay? And it may extend up and down a segment or two, because most of our muscles are innervated by more than one nerve, spinal nerve root and segments. Another thing your book talks about is fast and slow twitch motor units, okay? So you guys have learned about those in the past. Slow twitch or type 1 muscle fibers are postural and slowly contracting muscles, okay? So they're your postural set muscles that maintain certain postures. They contract, slow is a relative term in contraction times. They're a fraction, a little slower in how they contract, okay? They just don't generate the force and power of a traditional fast twitch muscle fiber, okay? Or, fast twitch muscle fiber. Fast twitch muscle fibers are also known as type 2A and 2B, okay? We're not going to get into, so there's also some other, types out there that people have started to look at, but just know that they're fast twitch and they're classified as type 2s, an A and B. And these are the phasic, more power-producing muscles. So when you need to move quickly, big amplitude, or quick and powerful movements, generate force in a small amount of time. Those are the fast twitch fibers, okay? They tend to be fatigued very easily, where the slow twitch are a little more fatigue resistant because they're turned on a lot of the time. Like your postural and gross movements are, they're the background contraction. Your core, you're keeping contracting all the time. They never quite turn off. But your phasic muscles, the power-producing muscles, tend to be more, they turn on quickly, they turn off for periods of time so they can recover. Okay. What's interesting is that your muscle fiber, what determines whether it's fast or slow twitch is not the muscle fiber, it's actually the nerve that's innervating it. They've actually taken in rat models and they've switched. They've taken the nerve from a slow twitch muscle fiber and put it onto a fast twitch and turned that fast twitch into a slow twitch muscle fiber. So it's depending, eventually your muscle fibers will take on the characteristics of what the nerve supply is to it, okay? So here's a kind of a interesting thing is that even though slow twitch muscles are a little bit slower in contracting, when they do get their signal, they actually get their signal first. They actually get the signal to contract. Like if you're going to do a quick ballistic motion, and I'm going to reach really quickly or I'm going to jump or something like that, when I start to send the signals will get to my postural set muscles just a fraction of a millisecond before they get to my other power-producing muscles. Even though then they still take a little bit longer to contract, because they got the signal a little sooner, still going to give them time to start to set before I do my big power-producing motion, so I don't throw myself off. Because I got to have this, I have to have the stability and the core to work off of with my power-producing muscles, and that's just because of the physiology. Because they're slightly different, even though they're both alpha motor neurons, they're slightly different. The ones that go to the slow twitch muscles actually have a smaller cell body. And because of the smaller cell body, their ability to depolarize is a little faster than the larger cell body. You don't have to exchange as many ions, and they depolarize a little faster. The axon sizes are pretty similar in size, but the smaller cell bodies that tend to go to the slow twitch muscle fibers depolarize just a little bit quicker, so they get their signal just a little bit ahead of time of the fast twitch muscle fibers. Does that make sense? Understand that peripheral sensory information, so somatosensation is critical to normal movement. You're getting feedback all the time. And so that's always influencing your motor output. So the sensory feedback you're getting from your muscle spindles, your GTOs, those are detecting rate of change, muscle length, tension, and telling your motor system, say, are you producing the right amount of power and force? Is there too much tension and force across this? Do I need to down-regulate the muscle? Or there's not enough force because this box is heavier than I expected, and I need to up-regulate the force. And so that's all happening at the spinal cord level and brainstem level and cerebral level. That information gets processed on a number of different levels and then activates your motor pathways to ramp up, ramp down, whatever it needs to do to modulate output. Okay? So that's just showing you, here's information coming in from the sensory system that's interacting typically with some interneurons in this area that can be excitatory or inhibitory interneurons. That helps upregulate the alpha motor neuron or downregulate it. You're getting input from other spinal interneurons, okay? You're getting input from upper motor neurons from the brain and brain stem that are coming down the descending motor pathways to influence. So your alpha motor neuron gets information from a number of different sources, okay? Let's talk about the concept of alpha-gamma coactivation, okay? So this is an important concept. During most movements, both the alpha motor neurons going to the muscle and the gamma going to the muscle spindle contract, so that as the muscle contracts, the muscle spindles also contract within the muscle, okay? What that does is it maintains the relative length of the muscle spindle within the muscle, so it stays sensitive to being stretched again. Because if you all of a sudden contract your muscle and the muscle spindle just kind of goes on slack, it actually quiets the muscle spindle so it no longer is sending a signal, okay? Your muscle spindles are always sending a little basal output, kind of a base rate of output. And then if you shorten it, the output rate goes down and turns the signal down. If you stretch it or pull on it, the signal rate goes up. And that's how your brain decodes whether my muscle's getting longer or getting shorter by the amount or the rate of pulses that are coming out of that muscle spindle. So at a certain resting spot, when your muscle's kind of in a nice resting position, and it's going to have this just normal basal rate of firing that says my muscle's in a nice resting position. If I go boom, out, stretch it farther, that rate's going to go up. If I contract it, it's going to go down, okay? So you don't want it to go down to zero, though, or you don't want it to go on so much slack that if I put it on slack and it doesn't contract with the muscle, there's a delay when I go to extend my arm again before it stretches enough to start sending enough of a signal to tell me my arm is getting, my muscle's stretching or getting longer. So what this does is, as you contract the muscle, it maintains the relative length within the muscle so that it's sensitive to another stretch or another shortening, so it can either upregulate or downregulate within the muscle. Does that make sense? So it's maintaining the sensitivity of the muscle spindle within the muscle so it never goes quite fully on slack, okay? This is showing you here, this is a muscle that is being at a certain resting length here, and this is the gamma motor neuron, this is the alpha motor neuron, I'm sorry, this is the gamma, and this is the alpha down here. And so here we have a certain rate of firing or signals being sent by that muscle spindle, telling you what the relative length or tension is of that muscle. Now, if I just sent a signal just through the alpha motor neuron and it contracted, now the ends of this muscle spindle go on slack, and now we're getting no signal from that muscle spindle. And no signal doesn't give us much information. At a certain point, it gets so on slack, no longer do I get continued information about if my muscle's getting shorter, okay, because it's turned off and it's not telling me even if it gets shorter. And if all of a sudden I decide to change directions and stretch the muscle, there's a delay because it's been on slack that it doesn't provide me information during the early part of that until it starts stretching enough to start sending a signal again, okay? So the fact that when you contract your muscles, you send a signal through the alpha and the gamma so that as you contract the muscle down, the muscle spindle contracts with it, so it maintains its ability to have a normal basal rate of signal sending so that it's still sensitive to either more shortening or more lengthening, no matter what position your muscle is in at any time. Does that make sense? Okay. They call it like setting the gain. You're keeping the gain or the sensitivity of it at the same no matter what position your muscle is. It's ready to send a signal if it gets a little longer or shorter no matter what position your muscle is in. Okay? All right. So any questions about that? So that's kind of looking at the peripheral motor system, some of the basic features of that. Now we're going to move into the spinal region and talk about some of the basic motor control at the spinal level. These are basic reflexes that occur at the spinal level. Most of these you've heard about one time or another. But there is a fair amount of motor activity and motor control that happens just in the spinal cord that we use as physical therapists every day with our patients and are critical to the normal motor function. First of all, you guys have learned about myotomes, okay? So myotomes are the groups of muscles innervated by mostly by a single spinal nerve, okay? So these are your common myotomes and the common movements that they create because of the muscle they primarily innervate, okay? It's not perfect, but these are typically so elbow flexion is mainly a C5 function, okay? So it's a myotome. So the alpha motor neurons that primarily go to muscles that flex the arm are in that C5 anterior horn area is where those are mostly located, then come out of that C5 nerve root, okay? Just to show you, just kind of looking at in the spinal cord what it looks like in different cross sections in the cervical, thoracic, and lumbar spine. And these are, you should be able to look at almost any diagram of a spinal cord, whether it's a line drawing, whether it's an actual specimen, and by knowing a couple characteristics, you say, that's a cervical segment, that's a thoracic, or that's a lumbar segment. So let's just go through those. So here is a cervical segment up top. Notice that it's wider medial to lateral than it is anterior to posterior. So it's definitely got a little bit more of a wider medial to lateral profile, okay? It's got these really big anterior horns on it. Big anterior horns, and sometimes the anterior horns are even got a little bit more complex looking, nature to that. Why do you think those anterior horns are so big in the cervical spine? Yeah, they're controlling all those little muscles and fine motor muscles of the forearm, hand, and intrinsic. It requires more anterior horn cells because actually you have more motor units, okay? Because you have to give that fine fractionated movement, so you need lots of control. So each anterior horn cell is only going to innervate a few muscle fibers. And so you need more anterior horn cells up there to innervate all these individual muscle fibers so you can get that really fine control, okay? And you need to make space for that. So that's why it's bigger. That's why the cervical spine they got the biggest cross section through it. And there's a kind of a bulge right here between the C5, 6, 7, 8 area, because that's going to all the hands and forearm muscles. And that's the cervical enlargement, they call that. That's a cervical enlargement. That can functionally be a problem, though, because it's a little bit bigger in your spinal canal. So people that get narrowing of their spinal canal, central stenosis, that's where the stenosis often happens, is in those segments there. Or little osteophytes that are like little bone spurs pushing in from the spinal canal, because you've got that little bit of an enlargement in this, encased spinal canal. It might push on those areas. So as a physical therapist, that's some, reason why it's important to understand that there's just less room in those areas. Another reason why you get more pressure and problems there. Now we come down to the thoracic spine. Notice it's smaller. It's in size. It's also more round in size. I forgot to also mention, this one doesn't show it great, but I'm going to change colors on this slide. You will see a little bump here and another bump here, so that you see both the fasciculus gracilis and a fasciculus cuneatus. So you see two bumps on the back there, so that helps you understand. Where in the thoracic cord, we only have the one bump, right? Because we haven't added on the upper body yet, so all we have is fasciculus gracilis there. Very tiny anterior horns. You know, why would you think you have very tiny anterior horns in the thoracic spine? So it's going just to some postural muscles that are kind of gross movement postural muscles, maybe just a few intercostals. There's not a lot of muscle out here to control in those spinal segments. There's just some intercostal muscles, some multifidi muscles, you know, and they're usually postural gross movements. So you have, you know, one anterior horn cell can supply a fairly good amount of motor fibers. Plus, there's not a lot of motor fibers to supply, so you just really need small. There's not a lot of anterior horn cells there. Okay. So that helps you know that you're in a thoracic spine. And the other thing that helps you know that is right there, the little lateral horns, where you have those sympathetic cells, cell bodies for the, you know, preganglionic sympathetic nerve fibers. So that's another giveaway that you're in the thoracic spine. Then here's lumbar. Lumbar is very round, and it's kind of almost the most rounded in nature, and it's almost sometimes a little wider anterior to posterior than it is the medial to lateral, but it's definitely more rounded, okay? It's got some pretty big ventral horns, okay? It's got, these are big muscles, even though there tend to be gross movement, but you got some finer muscles down in your ankle and foot, but there's a lot of, you know, your glutes, all that stuff, you know, quads, hamstrings, those are big muscles, so there's still a fair amount of anterior horn cells that need to be in there supplying that. And you'll notice you also have an associated lumbar enlargement because of that. And that's kind of in that, you know, L1 to S1 kind of region, you know, is where most of those lower body things are coming out. So, all right. Let's talk about motor neuron pools. These are the axons from a motor pool project to primarily to one major muscle, okay? These pools tend to be kind of arranged within the anterior horn in a certain way, okay? Anterior horn cells that are going to innervate primarily axial and proximal muscles, they tend to be located in this medial part or medial pool area of the anterior horn, okay? If the anterior horn cell is going to go out to innervate primarily distal muscles, it's going to tend to be more lateral, in a lateral pool of the anterior horn. If it's in an anterior pool, it's going to be more an extensor muscle that it's going to innervate. If it's in a posterior pool, more flexor, okay? So if you are in the, like, say, the anterior and lateral area, you're going to probably be an anterior horn cell that's going to go to more distal extensor muscles. So distal extensor muscles, versus if you're in a, you know, medial pool, and in the posterior part of the medial pool, you're going to be going to more proximal flexor muscles, you know, shoulder, hip, or something like that. So let me just show you a picture that helps make sense of this. So here's any anterior horn area. This works for both upper and lower extremity, okay? It's just easy to remember it by using the upper extremity as an example, because the way the arm fits in there is just a nice way to remember it, but it works for both upper and lower extremities. So when you look at the anterior horn, you know, if you've got some anterior horn cells sitting here that are going out to muscles, these guys will tend to be distal flexors as they're going to. So maybe flexor digitoris profundus or something like that, you know. Versus if the anterior horn cell's sitting here and going out, it's probably going to a distal extensor muscle. If you're in here and you're going out, you're probably going to be going to a proximal flexor muscle, you know, proximal flexor muscle. And if you're sitting down here and going out, you're going to be going to probably a proximal extensor muscle. Okay, that's kind of the general rule. Okay, when we talk about these motor neuron pools, and it makes sense. So when we start talking about the descending pathways, the medial activation system pathways tend to be medial and also more anterior. So they tend to stimulate proximal extensor muscles, okay? Some proximal flexors, but also mostly proximal flexor muscles. And then we talk about the lateral activating system. When it comes down, it tends to come down on the outside of the spinal cord and talk to these more distal muscles that control more fractionated fine distal movements of limbs, okay? So it's talking to the lateral motor neuron pools, okay? This is just showing you kind of the same thing. A similar representation showing in the cervical spine, you know, proximal to distal flexors extensors, where those anterior horn cells tend to sit when they go to supply those muscle groups. Same thing with the lower extremity, works the same way. So this is showing you, that outside of the spinal cord, your rubrospinal tract and your lateral cortical spinal tract are coming down in this area here, and so they tend to communicate with these more distal flexor motor neuron pools that are going to the distal flexors, where most of your medial activating pathways are coming down in this anterior and medial area of the spinal cord, so they tend to talk to these anterior horn cells that are located more medial, okay, and anterior, that tend to go to more proximal extensor muscles, so as a general rule. So when we start getting to these descending pathways and you talk about function of these descending pathways, it's easy to kind of understand. If you understand what the types of anterior horn cells are talking to, it makes sense why they primarily cause postural extension or distal flexion, just by knowing kind of this topical arrangement of how this stuff works. So now let's talk about some of the things of what happens from a motor coordination standpoint in the spinal region, okay? One thing that does happen is this thing called muscle synergies. So sometimes when you send signals down to your spinal cord, or your spinal cord works, you will activate synergistic movements. So a lot of movements we do are fairly stereotypical in nature. Things like bringing something to our mouth, whether it be a cup, a spoon, whatever, brushing my hair. There's a synergistic pattern that I use that gets me 99% of the way there most of the time. Then I make a few adjustments with my fine motor system at the end, but I use my, elbow flexors, my shoulder flexors, my supinators, all at the same time. And so when I send a signal down into the spinal cord, I'll activate multiple levels of my spinal cord in a synergistic way, so these muscles just tend to work together as groups. So I might be hitting C5, C6, C7, C8 to coordinate all those motor activities in a synergistic fashion, so they tend to work together. So muscle synergies are normal parts of movement that we use all the time. Kicking a ball, or just standing up from a chair is a synergistic extensor activity. You use your quads, your glutes, your gastrocs to push up from an object or push something away. We have these big synergistic movements. Throwing a ball is a synergistic kind of pattern that involves a diagonal type pattern. Some of that control happens in the spinal cord. It's not like you're sending individual signals to all these little muscles to do that every time. Once you activate a certain pathway, it says activate that synergy, and that happens. The spinal cord coordinates a lot of that, okay? So it doesn't like these discrete little signals you have to send to every muscle to do that, okay? It's also true with some more complex movements like stepping pattern generators. There are reflexes within my spinal cord from my lower body between, that L1 to S1 region that automatically, if I send the start signal down from my cortex, once they get going, they tend to keep going. And they're self-perpetuating, these coordinated reflexes that cause these stepping reactions. As long as I don't encounter an obstacle I got to negotiate around or step over or something, or people aren't in my path, there's not distractions, most of walking can occur with just spinal cord and a couple occasional impulses from the brainstem as well to kind of keep it primed and going. And that's why you can put somebody with like a Christopher Reeve or somebody with a complete spinal cord injury and elicit some what look like fairly normal type steps, even though there's no real direct connections. That's all mediated by spinal cord. It's not perfect. You still need some cortical and brainstem influence to make it look just right, but you can get a lot of the basic motions without thinking about it, without having to think, I need to take another step, I need to take another step. Once it goes, it kind of keeps going. And remember we talked about those reverberating circuits where sometimes the axon goes back to the cell body? You have some of these in your spinal cord for stepping pattern generators, so once it starts, it wants to keep going until you consciously say stop. So that's stepping pattern generators. Or they also call them central pattern generators, CPGs. But there's other types of CPGs. The stepping function is a type of central pattern generator. Basic reflexes. We'll talk about monosynaptic reflexes, but there's also some more complex polysynaptic reflexes that go up and down a few spinal cord levels. And then also the concept of reciprocal inhibition happens at the spinal cord level. So starting with reciprocal inhibition, this is the concept that when you contract a muscle, when you contract the agonist muscle, the antagonist will be inhibited, so it doesn't restrict the movement. So when I contract my bicep muscle or extend my knee, if I contract the bicep, as I'm contracting the bicep, there's a signal that goes back to my spinal cord and through an inhibitory interneuron tells my tricep. It may have to go down a level or two because tricep C7, so it'll go down to C7 and it'll say inhibit triceps while you're flexing your biceps, okay? Same thing with the quad. If I'm extending the quad, it'll tell my hamstring to relax, but it's going to have to go down a couple levels to tell that hamstring to do that. And that's mediated by these, and we said, we got a lot of interneurons in there. That's an inhibitory interneuron. That the muscle spindle is what sends a signal back that tells me I'm contracting my quad. That muscle spindle signal says quad is shortening and it's going under an active contraction, turn off hamstring so you don't restrict that movement. Reflexes at the spinal cord level. Initially, they thought that reflexes were the way everything we did was reflexes, like it was a summation of reflexes. So all movement was a reflex. A visual signal coming into my eye causes a reflex movement of my shoulder to reach for this object. The hand touching the object causes a reflex to cause my hand to grasp it. Once the hand is grasped at a certain level of tightness, that causes the reflex for my bicep to come up. It hits my tongue or my mouth, that causes my tongue or my mouth to open to allow the liquid to go into the back of my throat. The liquid hitting the back of my throat causes a swallowing response, and it's this chaining or summation of independent reflexes. We obviously know that that's not true for all movement. Now, everything we do mostly is some blur between voluntary and reflex activity, okay? Not everything is pure reflex, not everything is pure voluntary, but there's certain motions and activities that are more reflex, some are more voluntary in nature, depending on like we talked about earlier, whether you're doing something if I'm sitting down and doing a very novel new task, that's almost pure voluntary motor output. But if I'm doing something that's a learned skill or just trying to stand up and not fall over, those are pure, almost reflex-based movements. Okay, but usually there's a blurring, there's a blend of voluntary and reflex movements. So some of these basic reflexes, we've all done this, is the stretch reflex. All the stretch reflex is telling us a couple things, but it doesn't tell us exactly where the problem is. All it does is an indicator of motor integrity, okay? It's a very crude way of assessing motor integrity. One of the problems is you can only test reflexes at certain joints that are easy to see this reflex happens. So there's only, our bicep, tricep, knee, ankle, or you can get reflexes at other joints, but it's just harder to get them consistently. There's not a great tendon to tap on. It's not the muscle and where the limb isn't easy to see movement, so it's just hard to get consistent reflexes. So all you're doing there is you're tapping on the tendon. That creates a quick stretch of that muscle spindle. Boom. It stretches. If it stretches too fast, it says, I better turn this muscle on to What's your stretch reflex? Part of the reason you have stretch reflex is that if you start to my knees start to collapse on me, and my quad stretches quick enough because it's getting longer here. It'll say, "Oop, you're collapsing, but you're still trying to stand up against gravity. Stop," or if I'm starting to lean forward like this, and my gastroc starts to stretch, eventually it pulls me back, and that maintains me within a certain amount of sway range. That we all have a little error in our system, but I'm waiting for my reflex to kick in and keep me in that. So reflexes have a protective role is one of the ways. They have other roles too. But so then you tap on that tendon, that signal goes back directly to, in synapses, even without an interneuron, to the anterior horn cell to cause your quad to contract. Boom. Have you heard people, like Bill Clinton did, a lot of people do, like step off a stair or something unexpectedly, and you start to, you're all of a sudden, if you do that, your reflex or your muscle spindles say, uh-oh, your quad muscle, the amount of length is changing too rapidly and for the contraction that you currently have, your limb will collapse and be no longer weight bearing. It'll send a massive signal to your quad to turn on really quick to protect you. The problem is if you're an older adult, if you haven't been doing a lot of exercise and you have weak tendons, boom, you pop a quad tendon, or boom, you pop your gastroc tendon. Now, if you do a lot of plyometric, I'm a very big proponent of doing plyometric activity as you age and maintaining it, because there will be a time in your life that you go out after you've been sitting for the last 10 years and play that pickup basketball game, or you take that wrong step off a step. And if you haven't been doing consistent plyometric activity to maintain the integrity of your musculotendinous junctions and also how your muscle grades its response to those unplanned motions, you'll tear a tendon. And that's how you'll tear a quad tendon or tear your patellar tendon or your gastroc. So, and that's why I don't ski and I don't play pickup basketball, because I don't do plyometric activities regularly. I'm going to start doing more of it because I think it'd be fun to be able to still do some of those things. I ride my bike and run in straight lines, but I'm getting to the point in my life where I know that my tissues are starting to dehydrate and get more fragile, that if I don't do it, it's going to come back to bite me sometime. And I have tons of buddies that just go out and wreck themselves, and then they've got 2 years of rehab, and their leg is, once you tear that gastroc or that quad, it's never the same. It's never going to be right again. So this is a monosynaptic reflex in this case. Causes autogenic facilitation. Autogenic means it facilitates so it's the muscle spindles in the same muscle it's facilitating. It's keeping itself excited. It's exciting itself. And then this reflex is the phasic part of the reflex. It's when you quick stretch, boom, it turns on. That's the phasic part. There is a tonic reflex too that we are unable to really test or feel unless the person has a neurologic problem, okay? Because normally if I slightly bend my knees here and I just stand here, my muscles are slightly on stretch and they're continuing to create autogenic facilitation. That's the tonic stretch reflex. That's mediated by those type 2 endings, the ones that are on the nuclear chain fibers. Once they're maintained that stretch, and it's going to keep, but it's hard to test that or assess that as a physical therapist because you can't tap on that. It's when the muscle's under contraction in a lengthened position that you tend to get that, or during like an eccentric contraction when you're lowering something and your muscle's lengthening, and so is the muscle spindle. It's continuing to stretch and it continues to facilitate. That's why you can generate more force with an eccentric contraction than you can with a concentric contraction. Because when you're doing a concentric contraction, your muscle's shortening and the muscle spindle's shortening too. So it still sends some signal, but it's less robust than if you're lengthening your muscle and contracting it, and the muscle spindle's also lengthening. It tends to be more facilitatory back to the muscle. So that's why eccentric contractions are great, but they can also make you damn sore, because if you want to cause lots of micro trauma to your muscles and maximize your muscle, but you're also lengthening and you're tearing some of the elastic elements of the muscle too. But it's great for building muscle, but just as long as you can warn your patients and know that they'll eventually recover, and not hate you. So the tonic reflex, though, you can, for patients who have excessive muscle tone, if I just take them through slow motion and I move them, and just even with slow movement, I feel resistance the entire way. That's the tonic reflex that normally in a normal nervous system, you have descending control that says, keep that tonic reflex at a reasonable level. Don't turn it on unless there's enough demand on the muscle to make it worthwhile. But when you just move somebody's limb with no pressure on it and the muscle doesn't have to be doing a lot, like just relax, give me your leg, you shouldn't feel resistance to that. But when somebody has problems with their brain or cerebrum, or brainstem, and those descending motor pathways keep that reflex dampened down a little bit, then you might feel resistance, abnormal resistance, this tonic reflex, even when you shouldn't have it. Okay. Let's pause here. I was thinking let's just keep going, but I think you guys need a break, and I need a drink of water. So, all right, come back in 10 minutes here. Cord. So back to the stretch reflex here. So when you test a reflex, what you're testing is the integrity of both, come on. You're testing the integrity of both the sensory part of it, that 1A afferent from the muscle spindle, and the motor part of it. Typically, these are all contained within the same spinal nerve, though, right? So you're essentially testing, one thing you're testing is the integrity of that spinal nerve, okay? If that spinal nerve is damaged or is being pressed on, both the signal that takes the muscle spindle signal back to the spinal cord might not get there, and also the motor signal coming from the alpha motor nerve might not get there. But we don't know why. We don't know if it's the sensory or the motor part. Usually it might be both, because it might be that whole spinal nerve being impacted or that peripheral nerve being impacted that don't allow both of those signals to allow that stretch reflex to happen, okay? So typically if I tap on somebody's tendon and it's low or absent or compared to the other side or what's expected for that person, then we would probably indicate that as probably likely a lower motor neuron problem or a peripheral nerve problem, because we couldn't get the signal back to the spinal cord to elicit a response, or the signal couldn't get out of the spinal cord to make it to that muscle, okay? So if you have decreased reflexes, deep tendon, myotactic reflexes, that's typically indicative of a lower motor neuron / peripheral lesion, because the lower motor neuron axons are in the peripheral nervous system. So if it's you can kind of say it's lower motor neuron / peripheral nervous system problem. But if the reflex is decreased. So normally what happens is, God, I hate this. I can't see with erasing. Frick. Okay. Your descending motor pathways, as they come down, some of them fall on little interneurons in here, and the little interneurons modulate that reflex. So it's not too high, not too low, so it generates the right amount of response to stretch, okay? So there's normally a little bit of descending influence from brainstem centers and cortical centers that modulate your reflexes at your spinal cord level. And they usually have a slight inhibitory effect. They keep them down regulated. They keep them in the middle. They're not too turned up or not too turned down. They down regulate. There's a little bit of inhibitory influence over your reflexes, so they're not too overactive. So what happens if you have damage to the descending pathways up here, now you no longer have that little bit of a inhibitory influence over the reflex. So when you tap on the tendon here and it connects and then synapses again, that signal is extra strong and you get a stronger reflex. So these guys are no longer having any supervision from above. They're kind of running amok. They're kind of just like doing what they want. So these little spinal cord reflexes can get overactive with a upper motor neuron problem. Anytime you damage any of the pathways before it hits that anterior horn cell, that's an upper motor neuron problem. So traditionally, when you tap on a tendon and it's super high, way higher than expected, you're thinking upper motor neuron problem, okay? If it's too low, you've damaged somewhere out here, probably the periphery or the anterior horn cell itself. That's a lower motor neuron or peripheral problem.
So say you have like a higher spinal cord injury,
Mm-hmm.
but your lower reflexes
Yes, those are usually these descending pathways. So like if you have a cervical spinal cord injury, everything below that, all the reflex loops below that will be impacted because the modulation comes from brainstem centers and cerebral centers. So you block the brainstem and cerebrum from delivering their influence and their modulating influence over those reflexes. Okay, so they get hyperactive typically.
So it doesn't just happen like between like your leg and like maybe like a thoracic area.
No, it doesn't happen between like the thoracic and lumbar. But so anytime you have, no matter where the lesion is in a spinal cord or in the brainstem, everything below it, the reflexes will tend to be higher. Okay. However, if I have a left-sided stroke that's affecting my cortical spinal tracts and even brainstem tracts on the left side, they all cross over to the right, so my hyperactive reflexes will be just on the right side because I've lost that normal control modulation over those reflexes. Okay. So that's what tapping on the tendon does. It just tells you when you're trying to screen somebody, you're screening and saying, is it too high or too low? If it's too low, is this a peripheral problem? And then I'm going to do some other, sensory testing and different things to confirm that. Or if it's too high, do they have a central nervous system problem? And I got to do some more testing to confirm do a Babinski reflex and do some other things to confirm that. Okay. Another structure that helps influence spinal cord reflexes is the GTO, the Golgi tendon organ. Okay. It primarily is giving us information about tendon tension versus muscle tension. They're kind of related. I mean, if you increase tendon tension, your muscles probably got increased tension in as well. But they're located more at the musculotendinous junction area, not in the muscle itself. We used to think that the GTO was a protective reflex, in that it was sensing tension in the muscle tendinous junction, and if it became too great, it would shut itself, it would turn the muscle off so you don't damage yourself. It's not an on-off switch like that. It actually is very dependent on the activity. Sometimes it ramps up motor activity, sometimes it turns it down. Depends on the task, the situation, and so forth. And it never works by itself. None of these proprioceptors work by themselves. When you're stimulating muscle spindles, you're stimulating GTOs. You're stimulating joint receptors. You're stimulating Pacinian corpuscles and Meissner corpuscles out in your skin. All of that stuff comes in, falls on interneurons, and it says, okay, depending on, am I standing on the bottom of my feet? Am I in an upright position? And I'm doing this task. How should I modulate my motor output to make sure that I'm successful with whatever I'm doing? Okay? So all this stuff is processed at the same time. Yeah.
So if that's like not their main function, like the shutdown thing, does that kind of invalidate like PNF stretching?
That doesn't leave out PNF stretching, where you contract, relax, the contract, relax kind of thing. It's not the GTO primarily that's doing that. It's actually a combination of all proprioceptors. So when I do a contract, relax, like have somebody push into me, they used to think that you push in, create lots of tension in the muscle, that makes the GTO turn on, and then when you tell them to relax, you get this refractory period where it's it shuts the muscle down, and you take advantage of that and stretch into that. Probably what it does is actually just, when you contract into somebody's, you're getting the pressure of their arm against your leg, you're getting lots of afferent information that comes in and bombards that dorsal horn. And what that does is, once you then stop that contraction, you do get some reflex inhibition of muscles in that area that's temporary that you can take advantage of. But it's not a pure GTO thing. It's just some probably reflex inhibition that goes on at that motor unit area or level based on all the massive afferent information that bombards it at one time. It kind of habituates to that afferent information, then turns itself down a little bit for a temporary period of time. Like I said, it may facilitate or inhibit depending on the task. During the swing phase of gait, the GTO may play an excitatory role in the hip flexor and the hamstring to help flex the hip and the hamstring more, because as the muscle spindle is shortening during flexion, the tension in the tendon is getting greater, and so, but during stance, it may, change in different tasks based on weight bearing and so forth, and how that affects tendon tension. So it just depends on the task. Okay. So maybe facilitating the hip flexor, but it may be inhibiting another muscle at the same time because it's shortening and losing tension in the muscle. So it's not that easy. Another thing they think the GTO does play, and it's somewhat of a protective role, is that you have these, feedback loops and reflex loops. Here's the GTOs, the little GTOs sitting at the tendon area, the musculotendinous junction. So if we're pulling tension in this muscle, you have GTOs that are spread throughout the tendon. If a certain GTO is getting too much tension, that individual GTO may go back, interact with an inhibitory interneuron, and say, hey, this part of the muscle, you're doing too much work. You turn down a little bit. Where these guys may not be getting enough tension yet, they go back and send an excitatory interneuron to say, you guys need to ramp yourselves up so we distribute the load more equally across this tendon so we don't get micro tears or trauma. So it might distribute the work of the muscle across the musculotendinous junction so it can act either inhibitory or excitatory to spread the load and modulate the load across. We also have some spinal cord reflexes that are mediated by cutaneous stimulation, so surface stimulation, okay? The flexor withdrawal response. So that could be lower body or upper body, and depending on what position. If you're not in a weight-bearing position, you're laying on your back and somebody tickles the bottom of your feet, or jabs you with a pen, you're just going to bring up your one leg, your right leg or whatever the leg that was stimulated, that plantar surface of your foot. That's a flexor withdrawal. Or I stick my hand on a hot stove, woo, I'm just going to do that. It's a flexor withdrawal response, okay? And it's multisynaptic. And so here is the flexor withdrawal response. So here's a foot here and a needle poking into the bottom of this foot. That sends a signal, fast pain, right? Up through the A delta fiber, goes in the posterior root, and remember we said that some of those fast pain fibers go up and down that dorsal lateral tract of Lissauer, a few segments. Part of the reason they do that is because they might actually go up and down a few segments to mediate these multi-polysynaptic reflexes that are a little more complex, because we have to activate hip flexors, hamstrings, okay, to do that flexor withdrawal response so that they move that foot away from that perceived threat, okay, that painful response. So that's just the pure flexor withdrawal response. We also have a crossed extension that is associated with the flexor withdrawal if you're in a weight-bearing position. So if you're standing up, if you have to lift one leg, you better extend the other leg, and you better extend it sufficiently enough so it doesn't collapse. So you communicate with the other side of your spinal cord and send signals to the extensor muscles on the other side through this multisynaptic pathway up and down to create the crossed extension. So flexor withdrawals if you don't have to do a weight-bearing thing. Cross extension is if you are doing a weight-bearing activity. Sometimes the cross extension, though, is also just to push away a perceived threat. So something's coming up and you're trying to push it away. So it's not always purely if you're just weight-bearing or not. Okay. Other cutaneous reflexes, the abdominal reflex. So you just take your, you take your tuning fork, your reflex hammer. You can take your nail and you just stroke it up the one side of the abdominal area, and the muscles contract underneath that and pull the umbilicus towards that side. Why do you have a abdominal reflex? What do you think that's primitively trying to do? What's that? Protection. It is protection. Yeah, you're just setting those muscles like could be a perceived threat impacting, pushing on my thorax or my trunk, and I better contract those muscles to protect my organs. So even just a slight stimulus like that will cause that to happen. Okay. Another reflex that we don't fully understand what it does or why, but it can be somewhat diagnostic, is this thing that called the plantar reflex. Okay. This is where you stimulate the bottom of the foot. It's not really a noxious stimulus, but it's not a comfortable, it's not a nice stimulus, not a massage. But you take typically your reflex hammer and you stroke it up the lateral. We're going to do this on Tuesday. We're going to do a little quick lab on some of these. Stroke it up the outside of the bottom of the foot and underneath the metatarsal heads, and A normal adult's reaction is the big toe and the small toes point down. They kind of just do a little bit of like almost a wink. They just kind of do that and they point down. And usually the other 4 toes come together a little bit when they do that, and then the big toe and they all point down just briefly like that. And it can be very subtle, you know, in nature, or it can be pretty strong depending on the patient's sensitivity, how ticklish they are, those kind of things. That's normal in an adult. You know, anybody that's over about 3 months of age, you know, and in most children after about 3 months of age. But an abnormal plantar response is when you stroke the bottom of the foot and the big toe extends and the other 4 toes tend to abduct or flare out a little bit and the big toe extends. That's called a Babinski sign, okay? Some people call it a Babinski reflex. It's really a plantar reflex, and I changed that on your slide or on your information outline here. So I'm trying to move myself to a terminology of using it. It's called the plantar reflex. If you have that big toe go up, and that's called a Babinski sign or a positive Babinski response. You know, so either it's a normal response or it's an abnormal, which would be the Babinski sign. Okay. If you have a Babinski sign, if your big toe goes up, that's a pretty strong indicator that you have an upper motor neuron problem. Normally those upper motor neuron pathways mediate that reflex and keep it, so that helps keep it a normal response where your toes are down going. If you stroke the bottom of the foot and that big toe goes up, that means there's some damage somewhere in the upper motor neuron. We can't tell exactly where. I can't tell you if it's the cerebrum, brainstem, spinal cord. There's probably other symptoms that I can help narrow that down, but that won't. All that tells me is upper motor neuron. Same thing with a hyperactive reflex. It just says upper motor neuron, but it doesn't isolate exactly where in the upper motor neurons that is, whether it's spinal cord, brainstem, or cerebrum. There's also a thing called the H reflex. We don't test the H reflex because you need an oscilloscope and a nerve stimulator to do an H reflex. The H reflex is nice though because you can't actually, you know, when you tap on somebody's tendon, we're doing a very crude grading system, right? 2+, 3+, 4, you know, and it's not a really exact way to quantify the we're assessing the excitability or lack of excitability of that monosynaptic stretch reflex. The H reflex is electrical equivalent of a tendon tap. You're using an electrical stimulus to do it, not the tendon tap. But you can, if you have recording electrodes based on the amount of the amplitude of the impulse you supply and then what you get back out of it, you can actually have a measurement of the millivolt amplitude of that, how hyperactive their stretch reflex is, okay, or their monosynaptic stretch, it's not a stretch, but it's just monosynaptic reflex, okay? So here you can see this. Usually if they're doing a lower extremity, the way they assess this H reflex is they put a stimulating electrode right behind the popliteal fossa. They put a reporting electrode usually on the lateral gastroc, okay? You send the impulse, you shock them essentially, okay? Because you're shocking the middle of the axon or the nerve, an action potential goes both ways because you're shocking the middle of it, right? So one impulse goes up towards the spinal cord via some of the sensory neurons, and one goes to motor pathway there, okay, because you're stimulating the whole popliteal nerve. What happens here is this impulse gets to the recording electrode before any other impulse, and that's the M wave. The M wave is the initial response of just the actual electrical stimulus that was sent. The initial volley of electrical stimulation that was sent arrives at that recording electrode. That's the very first little peak here in millivolts you see is the M wave. Now what happens is a brief millisecond or so later is this signal that went back into the spinal cord here through the sensory fibers stimulates the alpha motor neuron in that monosynaptic reflex and sends its signal all the way back down to the recording electrode again. It arrives just a fraction of a few milliseconds later, and then that's what's called the H reflex. That's that next stimulus there that is a higher stimulus typically than the M wave. And then you can actually measure that amplitude and get an actual readout. So sometimes they use these in studies. Like, for example, if you have like studies of spasticity, like if for spinal cord injury or stroke, if they're doing a therapeutic activity that's they're trying to down-regulate spasticity, maybe make it less, or they're doing Botox injections or something, a more accurate way to assess at least the physiologic outcome is if you decrease the excitability of the reflexes, do this H reflex testing. And so if that goes down, then probably you've improved or reduced the amount of spasticity in that limb. All right, here we go. So now we're going to get into, so we've talked about the peripheral part of this thing, the spinal cord kind of level and integration and reflexes. Now we're going to talk about those pathways. And they're not that hard. I shouldn't make them that hard. It's, if you kind of, like again, some of these you can kind of group, as far as function and the starting place and the ending place, the most of the names tend to tell you where the starting and ending, kind of similar to some of the somatosensory pathways. If you just break down the terminology and the name, that helps you. So we'll get started. Fortunately, you kind of know the different cross sections, so a lot of this stuff is easier because it looks familiar. So let's start with this medial activation system, also known as the posture and gross movement system. Okay. These are descending pathways that, in general, as a group, they tend to synapse on those motor neuron pools that are located medially and ventrally in the ventral horn, which tend to supply proximal postural muscles and tend to be extensor biased. Okay? So when you think about how these work all together, all 5 of these as a group, they will tend to contract postural muscles and they tend to bias extension as a group. There's some exceptions, and some of the exceptions depend on normal influence from higher centers of your brain, how well they work or don't work, okay? The other thing that gives it away that this is more of a gross movement, kind of automatic type movements, is 4 of them start in the brainstem, okay? Brainstem is more primitive, it's not at the cortex level. So there are 4 of them are brainstem tracks. However, 1 is from the cortex, but most of them are brainstem starting tracks. They start in the brainstem and end in the spinal cord. The nice part about all the motor tracks we're going to talk about is they just have 2 neurons in their pathway, okay? And we don't typically talk about a first order, second order, third order neurons. That's typically only we talk about in the sensory system. All of these are just 2 neurons in the pathway. So that's all you need to know about that. So the ones we're going to cover, that some of them, like I say, are not in your textbook, is the medial cortical spinal tract, the lateral vestibulospinal tract, the medial vestibulospinal tract, the tectospinal tract, which I starred because, like I say, it's not in this current edition, and then the pontine medial reticulospinal tract. So here's another cross-section through a spinal cord where we can look at these pathways. I like this picture here. It's a nice way to look at that. So if you guys are looking at this, on the left side, what they do is they kind of like 3D and highlight all the sensory pathways that go up the spinal cord. And on your right side, they're highlighting and showing all the descending or motor pathways. And it's like always like, how do they fit all that stuff in there? But yeah, it does all fit in there if you look at these and kind of see how it all fits in there, believe it or not. So I'm just going to circle for you. These are the ones we're going to talk about in the medial activation system. Those group right there of those 5 are the ones that we're going to be talking about right now. So, this descending pathway is coming down here. You notice how they're located here, more in this medial. They're near this medial and extensor, medial and anterior portion. So they're going to communicate with anterior horn cells that are more in this medial neuronal pool that are also more proximal. So, more proximal gross movements and extensor biased, okay? Our lateral activating pathways are these three right here, okay? This one's just a little more lateral. They're almost about the same, but anyway, these are our more lateral ones here that are tending to be communicating with these more distal neuronal pools out here. They're lateral neuronal pools in the anterior horn cells. Okay, terminology on this is what always kind of gets people messed up, but in this picture here, and even in your textbook for your the neuroanatomy textbook that you have, the nice Crossman book, this pathway right here in the cervical spinal cord, the medial vestibulospinal tract, some people, it starts in the brainstem as the medial longitudinal fasciculus. But some textbooks will continue to call it the medial longitudinal fasciculus down into the cervical spinal cord. They'll still call it the MLF, the medial longitudinal fasciculus. It starts as the medial longitudinal fasciculus up in the brainstem, but once it's in the spinal cord, it's called the medial vestibulospinal tract. Okay, and that's what we're going to refer to it as. So I just don't want that to mess you up. We will talk about the medial longitudinal fasciculus and the role it plays in a lot of different activities up in the brainstem, including influencing descending motor output for the upper cervical spine and upper trunk especially. Okay, I'll show you a picture of that in a few minutes here. So let's go through all these. Let's start with the one pathway that starts in the cortex. So the one medial activating or gross pathway, gross activating pathway that starts in the brain, in the cerebrum, is the medial or anterior cortical spinal tract. You'll hear it called, similarly. You hear one book call it the medial, one will call it the anterior. They're the same thing. Cortico, spinal. I know it starts in the cortex. Cortico, I know it ends in the spinal cord. It's corticospinal, okay? So you know it starts in this is a cerebral cortex pathway. Its main functions is it innervates or contributes to function of axial and proximal joint control, especially of the neck, shoulders, and trunk, okay? It tends to diminish as the lower you go down into the thoracic and lumbar spine. It doesn't play as big a role as you get down lower. It's more in the neck, shoulder, and trunk, and then not so much in the lower body is the influence it plays, okay? It begins, starting point, areas 4 and 6 of the motor cortex, okay? So we'll talk about, those are Brodmann's numbers. So there's these numbers that are associated with certain regions of the cerebral cortex, okay? At the end of this lecture, we go through the cerebral cortex, and you'll know what those areas 4 and 6 are in the cerebral cortex. Here's how it descends, okay? So we're going to follow, and it runs right along with the lateral cortical spinal tract that we'll talk about later for its first part of its journey until we get to the decussation of the pyramid. So through the cerebrum and most of the brainstem, it runs right along with it. So so here is some lower body and upper body motor fibers coming down that are both going to go down, and they're cortical spinal fibers. Some of those will end up being lateral cortical spinal tract, some will be medial cortical spinal tract. We're talking about medial cortical spinal tract right now, okay? But they're all running together right now. So they run down, starting through the corona radiata. That's this area up here. All the projecting neurons that come down through here, this is the corona radiata, is that area here. Eventually, they all get squeezed down into this area here between the basal ganglia and the thalamus. This little area, tight white area here that it gets through there, that's our internal capsule, right? Sensory fibers also going up the other way through there, but this is internal capsule. And it's the posterior limb of the internal capsule. Remember the sensory fibers are also going up in the posterior limb, so do a lot of your motor fibers. They're going down in the posterior limb of the internal capsule. Once they get into the brainstem, they're going to first go through the midbrain because they're going downwards, right? And they're going to go through this front part of the midbrain right here. that when you're looking at it in a cross section like this is the crus cerebri. If you're looking at it in a cross section, it's called the crus cerebri. If we're looking at it from the anterior view, I'm looking at the front of a brainstem, that's actually my cerebral peduncle. That's what you call it from the outside. It's that cerebral peduncle, but you look at it in cross section, it's actually called the crus cerebri. It runs down through the ventral pons. So these fibers are just going through that front basilar part of the pons, running down through the ventral part of the pons. Then once it gets to the medulla, it is in the pyramids. That front part, most medial front part of the medulla is called the pyramids. That's motor tracts running down the front part. Okay. Remember we said, a lot of our motor stuff runs towards the front part of our brainstem and the front part of our spinal cord, where generally more of the sensory stuff's towards the back. Okay, so this is running down the front part. And then it becomes, once it gets into the spinal cord, it stays on the same side right here. It doesn't cross. If it crosses over at the decussation of the pyramids, that's what becomes your lateral corticospinal tract. So these are the fibers that stay on the same side and don't cross at the decussation of the pyramids. Those are your medial corticospinal tract fibers that stay on the same side, at least initially. So these are the ones staying on the same side here, coming down in that more anterior medial position in the spinal cord as the medial corticospinal tract. But what it does, when it eventually gets to its different locations, primarily in the cervical and thoracic spine, they showed here going to the lumbar spine, but it does some, but not a lot. It typically ends and dissipates as you get lower. It will come down, and before it communicates with its anterior horn cell, it will cross back over in the anterior white commissure and synapse with the contralateral axon or anterior horn cell to supply those trunk muscles. However, it's not that simple. I wish it was. Know that the medial activating system, I don't know why my pen is malfunctioning and throwing those little straight lines in there, but there's also some ipsilateral and bilateral connections with this. It's not purely contralateral. So what I want you to know is it's not a pure contralateral pathway. Most of your postural and gross movement pathways have more complex connections. They aren't just purely ipsilateral or contralateral. Oftentimes they have more bilateral connections because you think about what your postural and gross they work in pairs a lot of times because they're having to turn on, turn off at the same time to set your postural tone and set to have your other muscles that work more independently work off of them. So they tend to have more bilateral connections. So that's why when you have damage to like a big stroke in your brain, their arm and leg can be totally limp and not working, but they can still have reasonable trunk function. They may have a little bit more weakness on the right side of their trunk, but it's not totally gone. It's because you're still getting bilateral connections from this other side of the brain that you get this more complex bilateral connectivity in those medial activating systems to maintain your postural trunk control, even despite having paralysis because of the lateral corticospinal tract. It's purely contralateral, but that's going to more of those distal fractionated movement. So you can be very paralyzed in your limb, but still have some trunk control, because those medial gross activating systems tend to still be working okay. So that's why it says it terminates more commonly in the contralateral motor neurons. So a majority cross back over, but then some communicate on the same side, and some actually have bilateral connections. So it's not a pure contralateral pathway. Some books will not even mention, some books will tell you it's a pure ipsilateral pathway. They'll say it only communicates with them on the same side, where in actuality, the majority of them actually cross back over and are contralateral in nature. Yeah.
So when we're studying these graphs for the test, do you expect us to know every specific thing that it goes down in? Or
You should be able to picture in your mind, and if you see something like, I know if something starts in the cortex, whether it's the medial or lateral activating system, they're all going to start by going through very similar regions, you know. And so if you just have that picture in your mind, I wouldn't necessarily get into memorizing every single part of this for every single track, but just saying, I know it starts in the cortex, I know it goes to the spinal cord, so it's going to have to pass through these characteristic structures, and so does any pathway that starts in the cortex, you know. So, and I would say focus on the slide information than the book information. I mean, complement it, but I would say this is what you want your go-to as far as what I would test on. Okay. So, and like I say, most of this pathway ends in the mid-thoracic region. So here's those area 4 and 6. So area 4 and 6 is, area 4 is your primary motor strip right there. That's that pre-central gyrus. Area 6 is both combined, what's called your supplementary motor area and your premotor area. Those are your motor planning areas. So this entire front part right here, this is area 6. And then back behind it is area 4. Those are Brodmann's numbers. Those numbers tend to correspond to functional regions of the brain. Okay. So that's where those pathways start. Let's just get into some cross-sectional anatomy here and start orienting you to this. So here's a mid-horizontal section through the cerebrum. Okay. Here you can see where the cut is. It's slightly oblique. It's not straight across, slightly oblique through the, you know, kind of in line with the neuraxis. The neuraxis is kind of oblique like that, and it's just a horizontal cut, and we're looking straight down from the top at that cut. Okay. All I want you to see here, here's the internal cap. Let me go to a different color. This is the internal capsule. This from back here, this is the posterior limb back here. There's a genu, a little bend right there, and then there's the anterior limb of the internal capsule. Okay, that's the white matter. Those are the axons that are running down from the cerebrum, but also a lot of them running up. Sensory and motor running through that posterior limb of the internal capsule. Here is your thalamus right here. And then this is your part of your basal ganglia structures out here, your putamen and globus pallidus together. So, and then this is also part of your basal ganglia, the head of the caudate here. So everything is kind of, that internal capsule is squeezed down between basal ganglia structures and thalamic structures as it's running down through there. This is just showing you, this is a netter picture here. A nice representation here of showing the different motor fibers from different regions of your body running down through that posterior limb of the internal capsule, through that crus cerebri, through the front part of the pons, and then some staying on the same side initially as your medial cortical spinal tract, and the other ones crossing to become your lateral cortical spinal tract. And they do maintain somewhat of a somatotopically arranged orientation as you go down through these regions, okay? And so here you can see, this is showing you the posterior limb of the internal capsule. This is actually anterior, and this is posterior this way. So this is your thalamus, so that's medial. This is your globus pallidus and putamen out here. This is your caudate, head of your caudate. So this is the posterior limb, this whole area here. These guys right here, you see face, arm, trunk, leg layered in that posterior limb of the internal capsule, those motor fibers. Just back behind that, that's the sensory pathways just behind that are also layered in going up. So you can see having a stroke right there would not be a good thing. You would wipe out a lot of stuff, motor, sensory function, that's all really close to each other in that internal capsule. So this is a neat dissection here they did where they kind of tried to expose the white matter and show the white matter axons. So they cut it away. All this is the corona radiata, all those white matter fibers coming from the cortex going down. What they've done here is they've taken, most of that the lateral part of the cerebral hemisphere away, including the basal ganglia structures, the putamen and the globus pallidus. And so here you can see this section right here to here. This is the internal capsule, and just beneath that is the thalamus. The thalamus would be sitting right in here, just beneath that. The basal ganglia are just more lateral, and they've removed the basal ganglia, so we're just seeing the internal capsule as it runs down. And then these fibers that run down the front are going to be your motor fibers. There's fibers going up the back here that are going to be your sensory fibers. And then there's some fibers running out here to go to the cerebellum, and some go from the cerebellum back up to the cortex. You can see those white matter fibers from the cerebellum through this right here would be the lateral, what is it called? Cerebellar peduncle. So the big lateral cerebellar peduncle. Okay. All right. Now here's a frontal coronal view. Corona radiata is these fibers that run down from here. Okay. This is a coronal section through the posterior limb of the internal capsules where this was taken. Okay. This is our thalamus on each side. Thalamus. This is the basal ganglia, part of it. This is the putamen, and then this is the globus pallidus externus. This is the globus pallidus internus, and then this is the head of the caudate right here, okay, which we'll get to not next week, but the week after. And then all this running down here is the internal capsule, and then right here is where the midbrain would start. So once it gets past here, in here it's the crus cerebri, okay, and then down to the front part of the pons. So it's kind of getting oriented again in the anatomy a little bit before we keep talking about some of the other regions. So we're still on this medial activating system, okay, these postural gross movement pathways, mainly in the brainstem. We just talked about the one in the cerebral cortex. Now we're going to talk about the four in the brainstem. So the first one we're going to talk about is the medial vestibulospinal tract. And starts right here. Why my pen? I got to reboot or something. So it starts right there. It starts in the, so let's talk about function. Regulates activity of upper back and neck muscles in response to vestibular input. So this is where, like, if my head starts getting tilted forward, my vestibular apparatus is telling me the angle of my head is changing. Turn on my upper back and neck muscles so my head doesn't flop forward. So it's turning those on to keep my head in this position. Or if I start to be tilted this way, it's turning on this muscle on the lateral, turning down this one if it needs to, or co-contracting them so they keep good control of my head. As I change positions in space, if I'm on a roller coaster, these medial vestibulospinal tracts are keeping my head in the right position based on the amount of information coming from the vestibular apparatus, which is telling about the angular velocity of my head, okay? So you've got your vestibular apparatus out here sending signals into the vestibular nuclei that tell you turn neck muscles on in response to that vestibular input without you having to think about it, okay? These are, again, more proximal, gross movement, near the center of your body types of activities. It begins in the medial vestibular nuclei. So this makes sense. It's called the medial vestibulospinal tract, and it begins in the medial vestibular nuclei. I like when they all make sense like that. So you don't have to memorize it because it tells you where it starts and where it's going. It's going to end in the spinal cord. It descends in the medial longitudinal fasciculus initially in the brainstem. So it descends in this little area here, right here, in the medial longitudinal fasciculus. And you notice it's right near the medial lemniscus, which is your sensory, your proprioceptive stuff coming up. And it's right near the medial lemniscus, kind of like right at the tip of the medial lemniscus. Once it gets into the spinal cord, then it is called the medial vestibulospinal tract. But we just call it the medial vestibulospinal tract. And it ends in the upper thoracic cord. It kind of ends, it doesn't go all the way down. It's mainly upper back and neck because it's just controlling upper back and neck muscles to response to your head position, okay? It's a bilateral pathway. It tends to terminate bilaterally in motor neurons of the cervical and upper back muscles. Even though this doesn't show it, there's bilateral connections, and those other ones cross over in that anterior white commissure. So a lot of bilateral connections for this one. Because anytime you're moving your head and doing things with, that's again, you want those both sides of the neck to turn on and coordinate with each other, okay? Medial vestibulospinal tract. Just so you know, and we'll get to this when we talk about especially vision and auditory information, what this thing called the MLF, the medial longitudinal fasciculus. There's a tract or pathway within your brainstem. What its primary role is, it connects several important cranial nerve nuclei for your vision and your vestibular system. It connects them bilaterally and all together, and it runs up and down between the oculomotor nucleus, the trochlear nucleus, and the abducens nucleus, which are your cell bodies and nuclei that control your eye movement, right? When we move our eyes, they always move together, don't they? You can't, I mean, maybe there's some people that can move one eye, but anytime you move your eyes, they're a conjugate. They move together. The MLF is what helps sync them all up so they all move together and move appropriately, and so that you have coordination of eye movement. The other thing you have to have coordination with is your vestibular system. So if I want to keep my eyes focused on Elizabeth back there while my head is turning, I have to have very good coordination between my vestibular system and my eyes so that my eyes can stay locked on her while my head is moving. And that requires my vestibular system to interact with my eye muscles to give the exact opposite movement to my head at the exact same degrees per second. And so all that has to be coordinated by these intimate connections between your vestibular nuclei and your oculomotor nuclei, and that's done through this connection called the MLF. Some of those connections have to descend also, and that MLF descends down to control some of the upper back and neck muscles that are mediated by these. These are vestibular nuclei sitting out here, okay? There's 4 of them. There's a superior, a lateral, an inferior, and a medial. Okay, so when we start talking about some of the other pathways that start another vestibular nuclei, that you'll know kind of there's this, they sit right here between the pons and the medulla, in that back part of the pons and the medulla. All right, so as medial vestibulospinal tract, yeah.
What happens to these nerves when like you go through whiplash? Do the connections get?
No, they shouldn't. I mean, these nerves shouldn't be affected by whiplash. What will be affected by whiplash sometimes is actually proprioceptors and nerves at your joints within your spine that proprioceptive intrip goes back to the spinal cord and contributes to motor control. It may make you feel like you're dizzy or don't have good awareness of where your head is in space, but it's not a vestibular problem. It's a proprioceptive problem of you damage some of the nerves that are supplying some of the joint. Small little tears of nerves and things like that, you know, so can grow back. Lateral vestibulospinal tract. Okay, so the lateral vestibulospinal tract facilitates anti-gravity muscles of ipsilateral extremities and inhibits non-anti-gravity muscles. So it provides excitation to anti-gravity muscles on the same side of the body as that tract is, and tends to inhibit non-anti-gravity muscles. So it's got a dual role. It's excitatory, but also inhibitory to another group of muscles, okay? It begins, fortunately, in the lateral vestibular nucleus. So lateral vestibulospinal tract, lateral vestibular nucleus. it descends in the lateral vestibulospinal tract. Well, that makes sense here. So here it is, starting up a little bit higher in the pons, but in the one of those lateral vestibular nuclei. So if we look here, here's our lateral vestibular nucleus right up here. It's just a little more lateral, but that's up more, a little higher in the pons, versus the medial here is a little bit lower down, more in the, so the medial is more down in the medulla down here, and the lateral is more up a little bit in that lower pons. So it's starting up here in the lower pons, and it descends, and just kind of stays as this lateral vestibular spinal tract all the way down into the spinal cord, and it terminates in ipsilateral. So this is an ipsilateral tract, but it's not that critical to know that from a physical therapy standpoint, okay? Because I really want you to think about the function of these medial growth activating pathways as a group, more so than individually. So, so these medial activating pathways, you can really, I want you to understand where they start, where they terminate, at least once in your life. But when you think about the role they play from a, a gross function and physical therapy, clinically meaningful standpoint, think about them more as a group and what they do, okay? And we'll get into this later about damage and what happens when you see symptoms associated with problems with these tracts, okay? So ipsilateral upper and lower extremity anti-gravity muscles. They tend to excite anti-gravity muscles, especially in response to if your head and is an upright position, it knows you're in upright position, so it stimulates muscles to keep you upright and keep your extensors stimulated, okay, when your head is upright against gravity.
So as a group, you want us to think of them as being bilateral?
Yep, I think as a group, mostly think about them as being more bilateral in nature. You typically aren't going to have, if you have problems with your medial gross activating system, it tends to not be as big a deal because you have bilateral connections. And so, but yeah. Now the tectospinal tract. Its function is to mediate reflexive movements of the head and neck to visual stimuli, okay? Remember the tectum? The tectum is the roof of the midbrain. And remember the tectum of the midbrain basically is your inferior and superior colliculus when you see them in a sagittal section, So we're looking at the side of a brain stem, and you see that little, that's the tectum, okay? So here, this region here, back here is the tectum. That's your cerebral aqueduct and your periaqueductal gray, but that back part of the brain stem is the tectum, the roof of the midbrain, which includes your inferior and superior colliculus, okay? The tectospinal tract is more influenced by, is more contributed to by the superior colliculus, the visual, but there is some fibers from the auditory or inferior colliculus to get in there too, but don't worry about that. So it begins in the superior colliculus. It actually crosses over in this what's called the dorsal tegmental decussation of the midbrain. This is your midbrain, and this area here, because there's these coming down here and crossing over here, this little decussation right here, this region right here is called the dorsal tegmental decussation of the midbrain. Probably not that critical for the exam, but just want you to be able to be a learned reader and understand this stuff. It descends in the medial longitudinal fasciculus, even though it should be over here. It descends and uses the medial longitudinal fasciculus because it's important for coordinating eye movements with head and neck movements, and if you got to have those all connected so it works properly, okay? Once it gets into the upper cervical area, it's called the tectospinal tract. However, some books will continue to call it the MLF, even into the spinal cord. So it can get real confusing depending on the resource you're looking at. So just use this presentation as your go-to. It's contralateral. It's a contralateral pathway for the most part. It's just really rare to have an isolated lesion of any one of these tracts. They work together. They're all running the same area. If you have a damage to your brainstem, you're going to involve a lot of those tracts, and because you have a lot of bilateral connections and they work collectively as a group, you're not going to see overt medial activation system pathway problems. You might see some weakness more on one side of the trunk or body than the other, one side of the neck than the other, but it's not typically totally paralyzed, okay? This is where, you want to look quickly to an object in your periphery, or you hear a loud sound, you turn your head towards it. This helps mediate that reflexive response to moving or diverting your head. Your eyes will divert too, but then it also tells your head and neck muscles to move your head to that position as well. This is the last medial activating pathway. I think is this number 5? So this is the pontine reticulospinal pathway, also sometimes known as the medial reticulospinal tract. I like pontine because it tells me where it starts. It starts in the pons, and it's in the reticular formation of the pons. We're hearing that reticular formation come up again. What does it do? It activates ipsilateral lower motor neurons of postural muscles and limb extensors, okay? This pathway, limb extensors, we're starting to see a pattern here. We're starting to see these pathways tend to accentuate extension because they tend to be anti-gravity in nature. These pathways tend to bias when you're having to be upright, standing, sitting positions. Because that's when your trunk muscles have to work more, right? And so that's why they tend to be biased towards extension. Some of these pathways work really normally and the way they should without really any input from higher centers. This is one of those. So it functions pretty normally with minimal input from the cortex. It's a brainstem pathway, but some of these brainstem pathways actually have a little bit of input from the cortex that help make sure it regulates, it's working properly. This one doesn't require a lot of input to give its normal amount of excitation to extensors, okay? Begins in the pontine reticular formation. So here it is right here, pontine reticular formation. It descends in the pontine medial reticulospinal tract, just descends down through the medulla in this kind of area, front part of the medulla and pons, and then into the spinal cord as the pontine reticulospinal tract. Stays the same name, okay? It tends to be more ipsilateral in nature. Ipsilateral motor neurons of postural muscles and primarily limb extensors. So it's coming down here and staying ipsilateral and communicating with those. Good. We'll come back to the whole this functions normally with minimal input from the cortex when we get next on Tuesday. We talk about damage to the different pathways and how that expresses itself and the characteristic symptoms. That's where we'll start to talk about these little subtleties of how these influence those symptoms and signs. All right, lateral activation pathways, less of these, right? And we've already gone through a lot of the structures we need to worry about and knowing that. So what do? These descend in the lateral spinal cord synapse with motor neurons in the lateral portion of the ventral horn, and they're for fine movement, fractionation of movement. So that distal control, voluntary distal control for the most part. Not totally, but for the most part. There they are, the lateral cortical spinal tract, the medullary or the lateral reticulospinal tract. So that helps me a little bit remember that it's a lateral activating pathway, the medullary or lateral reticulospinal tract, and the rubrospinal tract. So these are the ones we're talking about here. Okay, here's the medullary or lateral reticulospinal tract, the rubrospinal, and the cortical spinal. And notice how the rubro and lateral cortical spinal tracts are really, they meld into each other. Okay, they overlap some. Okay, they're very intimately tied to each other. So here's our classic motor pathway. This is the one that most of you maybe heard about or learned about in previous anatomy or physiology classes, is the lateral cortical spinal tract. This is the volitional fine motor control tract. It begins in areas 4 and 6 of the cortex, just like the medial cortical spinal tract. It descends in the same regions as the medial cortical spinal tract, but it crosses over. 85% of these fibers coming down cross over and become the lateral cortical spinal tract. The remaining 15% that don't cross, that's your anterior medial cortical spinal tract, okay? So 85% cross over in this decussation of the pyramids, in the pyramidal decussation in the, right here, in the pyramids. It terminates in motor neurons or interneurons in the ventral horn to supply distal muscles. 55% of your nerve fibers in that lateral cortical spinal tract are going to upper extremity anterior horn cells, 20% to the trunk, and 25% to the lower extremities, because your upper body just requires so much more innervation. Again, a reason why when somebody gets damage to their cerebral cortex or lateral cortical spinal tract, arm is often worse than the leg, because there's just, it's 55% is arm, okay? Next one is the medullary lateral reticulospinal tract. Its function is regulation of tone, okay? So it's more of a overall tone regulating influence than versus even though it's part of the lateral activating system, it does a little more in regulating tone that allows normal distal voluntary control, but it's not sending discrete signals to individual muscles to create the movement. It's just allowing this normal movement to occur better, okay? It tends to be more facilitatory than inhibitory. It tends to keep your tone at the right level so you don't have too much spasticity, and it allows for normal fluid movements and normal voluntary movement, okay? But it requires input from the cortex to do that job effectively, okay? In order to play its somewhat inhibitory role, it requires normal influence from the cortex to do that role properly. If you have damage up in the cortex, this guy no longer does its inhibitory role and things get too excitatory. It gets too excitatory. And what it does then is it over-facilitates flexors and inhibits extensors, okay? But during walking, that is a little bit of a reversed effect. Don't worry about some of that detail at this point. So it begins in the medullary reticular formation. Yeah, I know. In area of the reticular formation, so this is again the reticular formation, there's a specific area in there called the nucleus gigantocellularis. That's a defined region within the reticular formation called the nucleus gigantocellularis. Descends ipsilaterally, and some say bilaterally in the lateral reticulospinal tract. So think of this more as bilateral connections, okay? Terminates in motor neurons of postural muscles and limb extensors, primarily. So this seems like it should fit more in the medial activating system, right? But just because of its location, this tends to play a role like a medial activating system, but tends to influence some of the motor neurons going to more distal, some of the limb extensors more distally, okay? Especially the leg and the upper body. So it helps to modulate that and balance flexion with extension, okay? Because the rubrospinal tract is very heavily flexor biased. This one helps to balance it with some extensor bias, so you maintain that balance between flexion and extension. So you're always trying to maintain this optimal balance between flexion, extension of your limbs, also partially based on position of your body. And last one, rubrospinal tract function. There's the question mark. Some people, the jury's still out on exactly what the rubrospinal tract does. Like, it's much more pronounced in primates. Things that climb, animals that climb up things a lot and that require lots of limb flexion, okay? So they do think that it tends to be more innervate flexors of the upper extremity. It's the rubro. Rubro is red, right? So it begins in the red nucleus, and the red nucleus is in the midbrain, so that's this region right here. This one is a contralateral pathway. You should know that. You should definitely know that this is a contralateral pathway. It crosses over in that same area that we talked about, that other pathway that crossed over the tectospinal tract. Remember, the tectospinal starts up here and it also crosses over right here in that ventral tegmental decussation of the midbrain. Actually, it crosses, I shouldn't say it's the same, crap. I get ahead of myself. This is the tegmental decussation. There's a ventral part and a dorsal part. The tectospinal tract crosses over in the dorsal part, the back part or dorsal part, and this one crosses over in the ventral part of that tegmental decussation. Probably a detail that you don't have to know for the exam, though. It descends in the tegmentum of the pons. Okay, this is just that tegmentum out here, that kind of middle meaty part of the pons. It just descends out there somewhere in there. And the medulla, same thing in the medulla. And then it ends up kind of joining in and right next to the lateral cortical spinal tract in the spinal cord. So remember how you saw that yellow piece was kind of almost, partially within the lateral cortical spinal tract? It runs right with the lateral cortical spinal tract. Once it gets into the spinal cord, it meets up with the lateral cortical spinal tract. It terminates in motor neurons or interneurons in ventral horn to supply various muscle groups with emphasis on upper extremity flexors. Okay. The rubrospinal tract is also a tract that needs good cortical influence to function properly. If you remove the cortical influence, it activates your upper extremity flexors too much. That's why stroke patients, when you have damage to your cortex, now my rubrospinal tract no longer has normal control from the cortex and it gets overactive. And actually then that's why their upper body tends to go into this flexed position, is one of the reasons. They have an overactive rubrospinal tract. Okay? So the rubrospinal tract, in order to function normally, needs some continuous checks from the cerebral cortex to say, hey, tamp it down a little bit, keep under normal control, don't get crazy here. But if you lose it, then you get too much flexion. We'll get into cortical bulbar tracts and get to all the cranial nerves. Right now, all you need to know is that these are the motor supply to the cranial nerve nuclei that are driving voluntary control of moving our lips, mouth, face. If I tell you to raise your eyebrow, if I tell you to stick your tongue out, if you're communicating or talking, the cortical bulbar tracts are taking information from the cortex in that homunculus. Remember where the face and tongue and all that are represented? They come down through the front part of the midbrain and the front part of the pons. They all eventually cross over. They communicate with their cranial nerve nuclei, but they all are contralateral pathways. You do want to know that. These are contralateral pathways. The only one that's a slight exception is that the muscles of the upper face tend to have some bilateral connections. So the muscles of the upper face tend to get connections where you get bilateral innervation happening, so that if your stroke patient comes in and they're paralyzed on one side of their body, the lower face will often be drooping down and weak, but if you tell them to raise their eyebrows, their upper face tends to stay fairly okay, because if I've got a left-sided stroke that causes the right side of my face to get weak, my left side of my brain is still supplying both sides of my upper face. Okay, so if the upper face tends to not be as impaired as the lower face. You don't have to absorb all what I'm saying right now. We're going to do all this on Monday and talk about all these deficits, and we're going to go through cases and start to put it all together so it makes sense. Then we have non-specific activating pathways. All you need to know about these is there are a couple of them. It's the cerebrospinal tract. And we talked about a cerebrospinal tract for pain inhibition, but there's also a cerebrospinal tract for modulating motor output. Okay? These are descending brainstem pathways, and also a raphe spinal tract from the raphe nuclei, which are also in the reticular formation of the brainstem. Okay, down in the medulla, the raphe nuclei. Okay? These have general effects on motor performance and motivation. Okay? These are pathways that they think they have connections. The limbic system in your brain communicates with those nuclei. So if you're really nervous and anxious, this is where they think have you heard of somebody getting the yips, when they're golfing and you're standing over a putt that's worth $10 million and all of a sudden you just, knock it way past the hole. It's because these cerebrospinal and raphe-spinal tracts are going freaking out from the limbic system, getting you nervous, and it raises all your tonal set of your muscles because they just kind of go down to interneurons and say, you're stressed, you know, get ready, fight or flight, and it just kind of ramps up your motor output so that's harder. It creates a lot more co-contraction. It's hard to have a smooth motion. Or like if you get near the edge of a cliff or something like that, and you kind of stiffen up because you're trying to reduce your postural sway and all that, these cerebrospinal and raphe-spinal tracts tend to just go down and modulate overall motor output, up or down, you know, good or bad. Sometimes it's good, it's protective. Sometimes it gets in the way of smooth performance. When people are in the zone, you know, they talk about in the zone, but they probably are in the zone because that moment or that day, they did a good job of making sure these guys didn't get in the way of their motor output. Like, you know, when everything seems smooth and is not happening, or these are regulating in the right way. They're not overactive or underactive. And you wish there was a way you could predict that. Practice helps. Putting yourself in those stressful situations over and over again helps. But still, even the greats, you know, can still have a bad day where just these guys get the best of them. Now we're up in the cortex, the motor cortex. We have those areas 4 and 6. We have the primary motor area. This is movement, execution, and fractionation. More than 50% of your primary motor strip, which is that precentral gyrus, is hand and speech. The rest is leg, trunk, hip. The supplementary motor area, which is just in front of the primary motor area, but a little superior, supplementary, superior, I kind of think that, it primarily is active prior to bimanual tasks and sequential movements. So if I'm going to do a task where I'm going to like button a shirt or open a jar, or I'm using both my limbs or hands at the same time, some of the programs that are involved with that tend to be stored in that supplementary motor area. And some of that is learned over time, how to use your hands together in a coordinated fashion. And there's the little programs for that are stored in that supplementary motor area. So if you're going to do that kind of a task, that's where that signal tends to start, okay, in that motor planning area. Same with sequential tasks that require very sequential type movements that you have to do this before that, you know, those are stored in that area, okay. Premotor area, area number 6, my pen gave out, generates patterns of movements involving multiple muscle joints and groups of muscles, okay. So any kind of movement, you know, golf swings, large amplitude movements, you know, reciprocal type movements, those tend to be generated or stored or started in that premotor area, okay? And then we've seen those already. So you have the primary motor strip, area 4, and then you have the premotor area just in front of that, but more inferior, and the supplementary motor area more superior. I got us done a little early anyway. The lateral corticospinal is contralateral, no bilateral.
Why does it say 85%? Doesn't the rest of it goes to the other side?
The ones that stay on the same side are the medial corticospinal.
Okay.
Yeah.
Okay.
Yes.
That's why. Okay.
Yeah. Right.
This is a contrast. And then where does it